we are very fortunate that Professor Richard Love, who is a research professor, is here in Nepal from USA, Wisconsin with us, and he'll be talking about the oophorectomy plus tamoxifen topic in the breast cancer. And he has done several randomized trials, clinical trials, with the surgical oophorectomy plus tamoxifen with more than 1,700 Asian women. He has published more than 225 scientific peer-reviewed reports. He had very difficulty to earn US government research funding continuously for last 30 years. This is all said, however, his granddaughter is 5 says, I didn't know that grandpa was a doctor. I thought he is to me. So this is a short introduction. He is a well-known international researcher. So he will be talking about today about the surgical oophorectomy in a premenopausal woman in breast cancer.
Page down. Okay, so just some proof that what Professor Paudel just said, at least one part is true, okay? That my job, I work at my job sometimes, okay? In which, according to my granddaughter, my job is reading to her, okay? And that's the only job. All right.
So, is that particular introduce one was second?
Huh?
Okay. Welcome,
The story that I'm about to share with you really is actually more than 100 years old, but I'm going to talk to you about a component of it in time that started in 1991 when I went to Vietnam. And I went to Vietnam because I I had to resolve bad feelings that I had about the war in Vietnam. Now, that war preceded the lives of, I think, some of you. There was a war in which the Americans were fighting the Vietnamese for quite a while, from 1965 through about 1974. And that war, in America, we called that war the Vietnam War, and in Vietnam, they called it the American War. And lots of bad things happened in that war. And I was the age of some of you at that time, and I felt very badly about that. I felt like one of the things that I wanted to do in my life was somehow resolve my bad feelings about this, and that's what got me to Vietnam in 1991. And
Professor, I just want to remind you, your lecture is related to the telemedicine to other hospital in the other part of the country also.
So, and I want to look at where? Yeah. Huh? I want to look there. Okay. So, in 1991, I met this man, whom you see on the slide. And being a field surgeon in the underground hospitals in the central military zone, they weren't hospitals. They were underground rooms that the North Vietnamese thought were secure, and where they brought, for tonight it was this room, and they brought their wounded or people who were going to die and tried to take care of them. And tomorrow night, that room was someplace else. And Ben took care of people there for 12 years. 12 years. Now, just think of what that must have been. To me, that it must have been horrible. But what happened was, this man befriended me, and we started working together on treatment for breast cancer. And I think, as I've said in the label to this slide, I think he's a a War to Peace transition hero, and an unsung hero. So that's where this story started. The end of the story is that I think we have a treatment that could save 100,000 women a year in the world that is not being used. And as for you with numbers, for me, getting my head around a number of 100,000 is difficult, okay? I know about one or two. I was on the ward here today, and we saw some patients, and I understand this is a tragedy, this one patient. But tell me about 100,000 tragedies in a year, okay? That's a number I can't get my head around very well. But what I can say is, let me just recall one patient, and you all have had, I'm sure, similar experiences. But when I was starting out, maybe after 3 or 4 years in oncology, I had a young woman that I saw who was 36, who had young children and teenage children, and who I took care of for a while, and then we got in real trouble, okay? And she said to me, what comes next? And maybe some of you have some religious answers to questions like that, okay? But I didn't have an answer to that question, okay? What comes next? Where do I go, she said, okay? And so this is a story about trying to limit, in some way, those kinds of painful discussions. Okay. So
I think it's I think we'll just say hello to the other hospital also, so that they are listening properly. Good. So yes, Dr. Uday Sunincha? Hello? Sunya sir? Sunya sir. Please give your feedback, clear bhayera Sunya na bhane, So they are the surgeons in the other hospitals.
Okay. So in his recent book, Factfulness, the late Hans Rosling, who's a Swedish public health epidemiologist, has made the case that our assessments, us, Americans, international people concerned about health, our assessments of important global socioeconomic and health facts are critical to doing the right things about cancer, okay? Now, I can't present myself as any kind of expert about circumstances of clinical oncology and medical practice in Nepal. But what I can do is sensitize you to some global and scientific facts as I see them, most, of course, related to this particular subject, okay? But some bigger facts as well. So, as Rosling has done when he's had an opportunity to talk to international audiences like this, okay, Rosling has posed some questions. So I'd like to pose you 5 questions, okay, and get your answers to them, and then we'll come back and talk about the questions at the end of this presentation. Next slide. So here's the first question. Globally, most new cases of breast cancer each year are diagnosed in. So, how many of you think that the answer is A? Okay. So A, we've got a majority of people think the answer is A. How many people think the answer is B? Nobody thinks the answer is B. How many think the answer is C? A couple think the answer is C. Okay, so 1, A, majority, B, none, and C, a few. Okay?
So, any feedback from what you think, Dr. Uday? And the answer to this question?
What do you people think the answer is? A, B, or C? What did he say? He said,
What is the answer?
he thinks the answer is B. Okay?
We also think it's A. शून्य छ A. सुनेको छ
हजुर निराजनजी हामी यहाँ केही सुनेन
Okay? All right. How many people think the answer is A? Nobody. Here. How many people think the answer is B? Nobody. Oh, somebody thinks B? A. Okay. All right. Let's go back again. How many people think the answer is A? All right. A, maybe again majority. How many people think the answer is B? Nobody. How many think the answer is C? A few. Okay, so kind of the same pattern as the previous one. Okay? B, C, majority think A. All right, let's go to the next question. All right, globally, in premenopausal women with operable hormone receptor-positive breast cancer, adjuvant hormonal therapy can increase absolute 10-year overall survival by what percentage? Hormone therapy alone in a hormone receptor-positive tumor. Okay? How many people think the answer is A? A? Any votes? Okay. How many people think the answer is B? B? Okay. How many people think the answer is C? Okay.
So, Dr. Uday, what is your guess? So, Dr. Uday, the question Dr. Uday, सुनिए ना?
सुनिरहेको छ
So, what is the percentage of patient will benefit with the adjuvant hormone? Would you like to guess?
C.
C.
C, he says. Okay. Finally, let's go to the next question. Just two more questions, okay? Then we'll get out of school. Next. All right. At 5 years, among women in many populations, high-income countries, middle-income countries, low-income countries, who have appropriately been given adjuvant hormone therapies, the fraction of women that have taken these therapies for the entire period of 5 years. How many people think the answer is A? Nobody. How many people think the answer is B? Nobody. How many people think the answer is C? So everybody thinks the answer is C.
What from model?
C.
C. C.
C. Oh, okay. So everybody agrees that the answer is C.
Pattern liberation.
A pattern from Partner Hospital, doctor? Anybody would like to guess? Sunin sir, Partner Hospital? Huh?
Mute, sir.
Huh? Oh, would you like to guess? Compliance adjuvant treatment ko kati hola percentage? Would you like to guess, anybody?
C.
C.
C. Okay. Finally, last question. Next slide. Finally, for women receiving adjuvant chemotherapy, not hormone therapy, okay, impairment of cognitive function has been clearly demonstrated in less than 10%, 25% of patients, half of patients. How many people think the answer is A? A. So a few people think A. How many people think B? A couple people think B. How many people think C? So there seem to be a number of people who belong to the school of no opinion. All right.
Well, what about from Pathan Hospital? Model and Pathan?
I think A.
Okay.
Okay, we'll come back to these questions at the end. Okay, let's go to the next slide. Okay, you don't have a national registry, but you have some registry data, and there have been some estimates based on similar populations about the size of your breast cancer population in your country. And the estimates from GlobalCan are about now, if you update them, are about 2,000. So that translates, if you think that about half of your patients are premenopausal and half are post, it means that about a quarter of your total annual population are hormone receptor positive women who are premenopausal. Somewhere in the neighborhood of 500 to 700, okay? So what we're talking about is a substantial population, a substantial fraction of your breast cancer cases, okay? Which is why this discussion is worth your spending a few minutes with me thinking about. Next. So, it matters to this lady, okay? It's all about patience, okay? Next. So, how do we think about value and quality in cancer care, okay? These are the very real issues. This is the fancy technical language. We regularly talk about it, okay? But it's important that we be very clear when we start talking about measurement, okay? So, efficacy, safety, and of course, efficiency. Next. So, when we come to hormonal therapy for premenopausal women, okay, the high-income standards of care at the present time are 10 years of treatment with LHRH agonists and tamoxifen, or tamoxifen alone, or combination of the two. I'm not going to talk about aromatase inhibitors. We'll touch on that at the end, okay? Or maybe a combination of the two for 5 years followed by tamoxifen, okay? So, thinking about value and quality measures with respect to these interventions, you can see that the efficacy is related to the regularity of receiving the treatment, but also there's a lot of uncertainty, and there's no good way of measuring whether your individual patient is in fact being effectively treated. You can't measure estrogens and know whether in fact things are working the way they're supposed to be working. Obviously, getting monthly LHRH injections is inconvenient for patients, okay? A major issue is that if you put LHRH agonists into the mix, okay, regardless of what else you do in terms of hormone therapy, if you combine LHRH agonists with tamoxifen, you give LHRH agonists alone, okay, you get bone loss. The efficiency is poor because costs are high. Tamoxifen alone, the efficacy is reasonable if it's taken, okay? In premenopausal women, tamoxifen alone is associated with bone loss, okay? And the efficiency is fair. With your prices, it makes sense. Okay, so what do we get to? We get to a not affordable, not convenient, hard, impossible to complete monthly treatments, bone loss, issues. These guidelines are impractical for you. They're impractical in most places in the world, although people have yet to engage them. I'll talk about the issue of chemotherapy in the mix down the road. Next. So, the case I want to make to you is that if a quarter of your patients are premenopausal, hormone receptor positive treatment, and their targeted therapy treatment doesn't work, it isn't applicable here, what on earth you're going to do, and what on earth is strongly scientifically medicine-based. And I'm going to make the case to you that surgical oophorectomy plus tamoxifen is the optimal treatment for reasons that fall into these three categories. Okay? Next. So, efficacy. So let's start with the issue of the combination treatment and its impact on hormone receptor positive, typical population of hormone receptor positive women. These are our data from Vietnam, from a trial started in 1992, when other therapies of any kind were not available in Vietnam. In fact, lots of people didn't get treated at all, okay? And the important thing you see is that with 5 years of tamoxifen treatment, surgical oophorectomy that was done at the same time the initial primary breast surgery was done, the 5-year disease-free survival was 83%. And in a control group of women, the 5-year disease-free survival was 61%, okay? And what you see that's very interesting is a lag in continuing benefit from tamoxifen, we think, that extends out to 7 years, okay? After which there seems to be a drop-off in disease-free survival, okay? In both cases, you see a downward trajectory of the curves over 10 years. And those of you that are familiar with the literature know that this disease, hormone receptor positive breast cancer, is a chronic disease characterized by recurrence out beyond 20 years, okay? And these data emphasize that. So we got to think about it in chronic disease terms. Next. If you ask, what about the impact on survival? Okay, the impact on survival is huge. These are the only solid controlled data about this combination therapy versus no adjuvant treatment. At the same time I started this trial, Richard Pito started a trial in China, and what happened was the clinicians all gave other treatments and chemotherapy, and they never got an answer, okay? So the 10-year impact is huge, is absolutely huge. Now, you can say, because you're thinking back to the question that I posed to you later, wait a second, okay? This impact here is 33%, okay? Gosh, that's higher. And those of you, and I'm sure there are some, are very familiar with the printed literature and meta-analysis literature, and you'll tell me that that literature says that the impact of hormonal therapy at 10 years might be 10% or 15%, okay? Why is it that I can try and put up data like this and have you believe it, okay? And the answer is that the early hormone treatment studies that are the basis for the meta-analysis report, okay, are in much lower risk patients, okay? This is a heterogeneous population, 60% of whom were AX30 node positive. The median tumor size was 4 centimeters, okay? So they were a higher risk patient population, and the proportional benefit is, as a consequence, significantly greater. Now, what about, next slide, this question of oophorectomy plus tamoxifen whether it's medical oophorectomy or surgical oophorectomy, being more effective than tamoxifen alone. One of the reasons that we've had some trouble, and by we I mean me talking about surgical oophorectomy, getting people interested in the combination of surgical oophorectomy and tamoxifen is because people have said it's just the same efficacy as tamoxifen alone, okay? Because there weren't a lot of data that addressed this situation, okay? The data were this too small international trial first listed that showed a suggestion that combined hormone therapy was better, but it was a low-risk population, and you can see that both patient groups were doing well. The early reports of a big international trial called the SOFT trial showed, again, a suggestion of some benefit from the combination. We're talking about a population that was going to do well anyway. What's now just been reported has been the long-term follow-up data showing very definite overall survival benefits, okay? And when you start getting into higher risk population groups, the last column on this slide, the overall survival difference got up to about 4.5%, okay? And these were significantly, statistically significant differences, okay? Now, it's important to understand a principle that came out of where the best data are from the meta-analysis data, okay? That for types of breast cancer, the kinds of interventions tended to be associated with a proportional hazard risk that was the same regardless of whether the patients were at higher risk or had higher stage disease or lower stage disease. So the risk ratios, okay, were for node-negative disease with tamoxifen, let's say 0.4, okay? But for node-positive disease, the risk ratios were 0.4 as well, okay? Well, when you get to higher risk populations, hazard ratios that are the same as for lower risk populations translate into greater absolute benefit, okay? So the absolute benefit here of 4% in a patient population that's doing very well, if we then turn to a higher risk population, such as the populations I'm going to show you that I've worked with, okay, what we see is absolute greater numbers in terms of benefits. Next. One of the things that came out of the SOFT trial that has been exciting is that the combination of oophorectomy plus tamoxifen. In the SOFT trial, most of the patients had their oophorectomies with medical treatment, okay? But some had surgical treatment. Because for a long time, and it's still the case, it's thought that medical treatment and surgical treatment are equivalent in terms of efficacy, okay? One of the, quote, surprises out of the SOFT trial, just reported, was that HER2 positive patients, okay, had much greater benefit, relatively speaking, than HER2 negative patients, okay? And there was no question about the interaction here. And think of it, look at that figure. The HER2 positive patients had an overall survival at 8 years and disease-free survival of 85%. The HER2 negative patients, 82%, okay? The HER2 positive patients did better despite the fact that they got no trastuzumab. They got no antibody treatment, okay? Right? And everybody's aghast at this and saying, you know, well, this is interesting, okay? Everybody is aghast at this except me, okay? And the reason I'm not aghast at this is because, next slide, in 2003, we reported that this was the case. We reported very similar hazard ratios to the hazard ratios I just showed you, indicating that HER2/neu positive patients benefited more from oophorectomy and tamoxifen than tamoxifen alone, okay? Much more, okay? So this was old hat, okay? So those of you that read the New England Journal of Medicine, in about a week or two, you will see the letters about this trial and how we ought to react to this. And the first letter you'll see is a letter from me saying, among other things about surgical oophorectomy and tamoxifen, okay, this HER2/neu observation is something that is important for people where, okay, the cost of trastuzumab is big. Next. So now I want to talk to you about two clinical trials that we did looking at the relationship of menstrual cycle history and progesterone levels and differential outcomes from surgical oophorectomy. Okay? So by history I mean we asked patients and got history data so that we were able, by history at least, to say where we thought people were in their menstrual cycle on the day they had surgery. Were they in the first 14 days, in the follicular phase? Were they beyond 14 days and therefore likely to be in the luteal phase of their cycle? Okay? Now, you know, okay, particularly the younger physicians know because the gynecologists teach you about this, okay, that as women age into their 40s under stress and so on, okay, prolonged follicular phases occur. Women do not ovulate right on day 14, okay, and those numbers tend to go up as women age, and certainly in the population of patients we see the most of who are premenopausal, women in their 40s, this is an issue, okay? So history itself is not good enough. So we said a priori in both of these trials, we will randomize the patients according to history, but we will get blood tests on the day of their surgery to try and determine more accurately where physiologically they are in their menstrual cycle on that day, okay? And the analyses that I'm going to show you reflect that approach. So here in an adjuvant study of 740 patients, in the randomized patients, here's what we saw. I say randomized because there were some patients who were assigned to treatment without randomization, okay, for a variety of reasons, okay? So it's the randomized data that are important. And here's what happened in the three hormonal groups we were able to define. So the first hormonal group is FOL, HX means history, PG less than 2 means follicular phase by history, progesterone level less than 2 nanograms, which confirms that they were in the first 14 days of their cycle. They were pre-ovulation, okay? The second group is LUT, means luteal history, PG greater than 5, meaning their progesterone level was greater than 5, consistent with them having a corpus luteum cyst formed and making progesterone, okay? And the third group are luteal history, meaning greater than day 14 in their cycle, but a progesterone level of less than 2, suggesting that they hadn't ovulated, they didn't have a corpus luteum cyst, and they had, we can call it either prolonged follicular phase or luteal phase unconfirmed. We called it luteal phase unconfirmed. Now, what do we see in these graphs? What we see is that the bottom curve is the unconfirmed luteal curve. okay? And the other two curves are confirmed follicular or confirmed luteal. And it looks like these curves are significantly different. That is to say, the unconfirmed luteal curve is significantly worse, okay? And, next slide, this was confirmed. No, you jumped. Can you go back one? You didn't? In this, there should have been an overall survival curve here. Okay, go to the next slide. Okay, now go to the next slide. Huh. Or maybe we'll see it in a minute. Okay. If you do a multivariable model so what I've shown you are what are called Kaplan-Meier curves, okay, survival curves, not correcting for potential differences in risk factors for recurrence, okay? If you do a multivariable model correcting for risk factors, what you find is the luteal phase patients there's no question that the luteal phase patients who have low progesterone levels, okay, do worse. No question about it. Next. In fact, the difference with follicular phase or luteal phase is in fact huge in these randomized patients. Next. There we go. There's the survival curve. And it's sustained through the survival curves. And you see that while the confirmed follicular and confirmed luteal curves are overlapping, again, this unconfirmed luteal outcome is significantly poor and poorer. And you can see that the timeline here is out to 6 years, okay? So we're talking about an early effect. We're not talking about something that's happening way later, okay? So the key point is the efficacy of surgical oophorectomy depends on the hormonal status of patients when the surgery is done. Next.
एउटा सर्जरी गरेर मेन्स्ट्रुअल साइकल पनि विचार गर्नुपर्ने भयो ओपरेटिभको डेट दिँदाखेरि.
So that was our adjuvant study. A metastatic study was structured the same way. Randomization was by history, but the assessment was according to measured hormone levels at the time of surgery. Okay? This was basically a population of people who presented with metastatic disease a priori, on presentation. They never had adjuvant treatment, they never had chemotherapy, they never had anything, but they had incurable metastatic disease, okay? But they were clearly premenopausal. And what you see on this curve with a gold standard outcome, overall survival, is the curve to the left is the curve for unconfirmed luteal patients, okay? That is to say, again, the same group with bad outcome. So they're dying faster than the others. Now, typically, when you look at curves like this, you say, you know, well, you could say to me, oh, Dr. Love, I'm not very impressed. Those curves aren't very much different, okay? Now, when you look at a therapy and you have to apply curves like this to your patient, the best you can do is you have to say, well, look, if my patient is the average patient, okay, how much difference does it seem to make, okay? So if you look at the average patient, what that means is let's look at the median survival. There we go. Okay?
But the screen doesn't work.
All right, sorry. Yeah. So go put it on the 0.05 and on the curve to the left. So go up. So go straight up. No. Okay. You have to ask yourself, if my patient is the average patient, that means my patient is the 50th patient out of 100 to die, okay? You see that my patient, if she gets a luteal phase surgery, which is unconfirmed, my patient dies maybe at about 1 year, 8 months, something like that, okay? So then go along to the right and say, well, what happens if my patient was in confirmed follicular phase or confirmed luteal phase, okay? And you see that the time there, the time difference is actually about 11 months, okay? Now, if you look at reports now about efficacy of new therapies in patients with, quote, incurable disease that the medical oncologists are telling you, we're all excited, okay? And then you say, well, how much was the survival improved? And they say 6 weeks, okay? All right? And then you go back and say, I'm glad I'm a surgeon, okay? But here I'm telling you, we saw a difference of 11 months, okay? And these were young women with young children, okay, where it makes one huge difference if mother survives an additional 11 months, on average. And that's the best you can say about trying to apply these data in the real world, okay? Now, what's important for the case I'm trying to make, that this is an important observation, that unconfirmed luteal phase patients do badly, is this is a second randomized trial where a priori we said this is what we were going to look at, okay? A completely different group of patients, and we get the same result, okay? Now, the standard in the United States for approving a drug treatment for a particular condition is 2 randomized trials, one of which shows statistically significant difference, and a second which is supportive of that conclusion, okay? So this isn't a drug trial, this is a surgery trial, but it meets that standard. Next. So, one point I want to make, okay, is that looking at our patients overall, okay, all red scores for the level of hormone receptors in tumors categorize patients significantly in a significantly useful way. Generally, worldwide, about 75% of patients have high all-red scores. That is to say, the intensity of the staining and the fraction of tumor cells staining positive generates a score which is 6 to 8, okay? Patients who have lower scores, okay, have less intense staining, have a smaller proportion of those cells that stain positive, okay, unquestionably benefit from hormone treatment, but as you can see from our data, they don't benefit as much, okay? So it even more strongly makes the case that if you have a patient, okay, that is hormone receptor positive and particularly hormone receptor double positive, ER and PR positive, okay, that patient is going to get a huge benefit out of this kind of therapy, okay, if she can get the therapy, okay, which is a component we'll talk about now. Okay, next. Safety, big issue. Next. Adverse events. In the adjuvant trial, we had, when you surgeons present data at meetings of interventions, people ask you for 30-day morbidity and mortality, okay? Well, this was a surgical intervention. Our 30-day mortality was 0. We had 1 pregnancy that obviously occurred before the woman had her oophorectomy. We found out about it about 4 months into the pregnancy. The tamoxifen was stopped. Tamoxifen can be a teratogen, it's thought. In this case, the baby was normal on delivery. We saw only 1 endocervical cancer in 3,500 patient years of treatment, a much lower rate than has been a cause for people jumping up and down in the West, okay? We had a couple of
Normally how much? This is, what about incidence of
in the cervical cancer in the normal people?
Well, it's hard to make something out of one case in 3,500, okay? But it's not, it's hard to make the case that that's greater or less than you would expect, okay? But it's clearly not greater. We had a couple of pneumonias, a couple of DVTs, but this was from combined surgery, a little more prolonged. We might have expected more DVTs, pneumonias, complicated. We didn't have them, okay? Next. Bone. We combined tamoxifen with oophorectomy in the initial trial that I showed you starting at the beginning, okay? Not because we thought that the combined hormone therapies would be better. We combined the therapies because we had just reported in a New England Journal of Medicine article on the concept, introducing the concept of SERMs. SERMs means selective estrogen receptor modulators. The idea was raised that some drugs that were like estrogen, a tamoxifen was an example, okay? That these drugs were not necessarily purely estrogenic or purely anti-estrogenic like tamoxifen, but that there was a class of drugs, a new idea, a class of drugs that were in between that were SERMs, okay? And in 1992, this was an idea, okay? That it seemed like this could be true, but there was no biological proof that in fact this was the case in human beings, okay? And in 1992, we made the case. We published a paper showing that tamoxifen is estrogenic to bone. We clearly knew it was anti-estrogenic in the breast and to breast tumors, but we proved that bone density went up with tamoxifen in postmenopausal women, okay? So the concept of SERMs, we proved for the first time, was for real, okay? So we, at the time we started the trial in Vietnam, we put tamoxifen into the mix, not because we thought that the combination of oophorectomy and tamoxifen would be better. We put it in because women in Vietnam upload for a living, okay? They don't download for a living, by which I mean they work. They work in the fields, and they plant rice, and they pick rice, and so on, okay? And we said, and we knew that if those women got osteoporosis, in those women that survived, got osteoporosis and had lumbar compression fractures, okay, that would be a death knell. In the sense that they wouldn't, it would be suspected that they had cancer, but importantly, that they couldn't work. And if you can't work in Vietnam and contribute to your family's livelihood, okay, you're expected to go out to the back rice field and stay there until you die, okay? So it was a big issue to make sure that people didn't have bone loss. That's why we did it, okay? So in this subsequent adjuvant study, we looked at bone mineral density longitudinally in our Vietnamese and Filipino patients, okay? And stunningly, what we saw was that there was no significant bone change at all in the femoral neck in both the Filipinos and the Vietnamese. For reasons of equipment, potentially for ethnic reasons, these populations were different in their baseline bone density, and that's why you have the two regression lines here. But they showed exactly the same thing. In the femoral neck, they didn't lose an ounce of bone, okay? Next slide. In contrast, in the lumbar spine, they lost bone density in both populations. The curve goes down, but after a year, they didn't lose any more, okay? Now, this is a big deal, okay? Because all other hormonal therapies, chemotherapies, all cause bone loss, okay? And bone loss in younger women translates into early osteoporosis, okay? Now in the West, okay, and in high-income countries, the answer is simple. Give another drug. Give a bisphosphonate, okay, to counteract the effects of the bone loss caused by your drugs, okay? Well, in our situation, you don't need to have another drug because they don't lose bone, okay? Those of you that have worked with bisphosphonate drugs know that the big risk of bisphosphonates is jaw osteonecrosis. And jaw osteonecrosis occurs in people with poor oral hygiene, okay? I don't have data, but I suspect that unfortunately you've got a lot of people who have difficulty with the situation of their teeth. So they're at risk for developing a nasty, nasty complication, even if you could give them bisphosphonate. Okay? So this safety issue with bone is important. Next. Efficiency. There are lots of ways you can look at it, okay? But in dollar terms, the return from a combination of surgical oophorectomy and tamoxifen is incredibly low. It's down in the cost per year of life saved area of vaccinations of one kind or another, okay? And it's practical. Every woman who gets an oophorectomy gets a treatment. It's unlike the situation with LHRH agonists where, as we're going to talk, guess what? There's dropout because of cost, because it didn't work right, because the patient gets fed up with it, whatever, okay? And the second half of the treatment, tamoxifen, is at least affordable. Now, I certainly concede that people have got to take the drug to get the benefits, okay? But at least it's an affordable and low side effect drug. Next. Okay, so what tends to happen is that people say to me, well, look, our standard of care is that, you know, certainly in node-positive patients, we give chemotherapy and hormonal therapy, okay? And I say, fine, okay, and why do you do that, okay? Where are the data to support that giving chemotherapy plus hormonal therapy, when you give optimal hormonal therapy, is in fact better, okay? All right, and the answer is that there are not data to make the case, okay? The best experiment was this experiment, which was abandoned, okay? Because what happened was they were seeing these results. These were patients who were treated with anthracycline, cyclophosphamide chemotherapy. These were all node-positive patients, okay? And they had oophorectomies. Most of it was surgical oophorectomy, okay? And over time, the addition of chemotherapy didn't do anything for overall survival. This was disease-free survival, but as you can imagine, we're talking about out to 10 years, okay? The curves were overlapping. And they said, there's no point of continuing this trial because we're not seeing any difference at all in one direction or another. Next. If you look at our data, and these people said, listen, these results in node-positive patients, I want to re-emphasize to you, okay, don't support the use of chemotherapy in hormone receptor-positive patients, okay? Next. At the same time, the soft trial data were published. There was published data from a trial called the Taylor trial, okay? And this trial took patients who had low risk of recurrence on a 21 gene expression trial, gave them hormonal treatment. And then for patients who had intermediate scores, they were randomized to be given chemotherapy plus an endocrine treatment or endocrine treatment alone, okay? And the results for those with these intermediate scores, okay, were, as you can see, no difference in disease-free survival at 9 years, No difference in overall survival at 9 years, and even in the highest risk groups, there was not a statistically significant difference. Okay?
So this is very important message. When you refer the breast cancer to us oncologists, sometimes we oncologists are tempted to start the chemotherapy once it comes to us. So not all breast cancer patients need chemotherapy. So
Major issue. Okay?
For locally advanced breast cancer with not-positive ovarian.
Locally advanced disease is another issue, okay, and that we should have a separate discussion about. Okay? Next. So these data, and then you look at a trial of CAF chemotherapy plus Zoladex, Gaserelin, an LHRH agonist, plus tamoxifen for 5 years. Their 5-year overall survival was 86%. In our node-positive patients, the overall survival without chemotherapy was 86%. Okay? Now, of course, there are different populations, and you could say to me, I'm comparing apples and oranges here. Okay? But these are the kinds of data we have that say that adding chemotherapy to optimal hormonal therapy in premenopausal women doesn't do anything, even if the patients are axillary node positive. Next.
This is really a big message, especially for oncologists for us, who are very tempted to prescribe that chemotherapy. When you see the patient, and on the top of that, you see the node positive, most likely almost all oncologists will jump into the chemotherapy.
So, practically speaking, I'm urging you as surgeons to tell the medical oncologists that you'd like to see or actually do surgical oophorectomy in patients at the time you do breast surgery, okay? If the patient has a documented hormone receptor positive tumor, okay? And from a practical standpoint, how do you deal with my issue that there's a bad group of patients that you don't want to do this surgery in, okay? What you do is you take a menstrual history and you focus on identifying day 1, okay? You consider how the surgical timing schedule works, when the patient can be here, when you can get an operating room, blah, 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 okay? Then you try and schedule a time when it appears by history the patient is likely to be in follicular phase, likely to be in the first 14 days, okay? And when surgery can be done in the next couple of days following doing a progesterone level, okay? And then you do a progesterone level. And if the progesterone level is less than 2, okay, you've got a patient that has confirmed follicular phase. Operate. If you have a patient that's in luteal phase and you have a high progesterone level, I can live with that, operate. But if you have a patient that by history is in the later part of her cycle, beyond 14 days, and has a low progesterone level, no, no, no. I can't tell you that we've 100% proven that such patients do badly, okay? But what I can tell you is it's impossible to make the case that they can do better or equally well to patients if you confirm luteal phase or you confirm follicular phase. Okay?
So if you don't have a facility to do the progesterone level, then don't do oophorectomy.
You do the best you can with surgery if you don't have progesterone determining capacity, okay? But I would think that you do. So efficacy. I've shown you the story about efficacy. Safety. I've shown you that, well, first, with respect to efficacy, surgical oophorectomy plus tamoxifen is unquestionably effective. Surgical oophorectomy plus TAM is more effective than tamoxifen alone. Surgical oophorectomy is best done in confirmed follicular phase or confirmed luteal phase. Surgical oophorectomy cannot possibly be worse in these phases than as it is usually done, okay? That using hormone receptor status is important, okay, in urging people about therapy and certainly feeling like doing this additional surgery is worthwhile, okay? That with respect to safety, in the real world, okay, the way to preserve bone mineral density in these patients is to do this, is to do surgical oophorectomy and give patients tamoxifen, okay? What I haven't told you is that if we put AIs in the mix, there are no data that show for sure that AIs are better, and that in the safety issue, AIs are terrible. AIs are terrible for the brain, they're terrible for the heart, they're terrible for bones, okay? And the soft data show that the combination of oophorectomy plus AIs is no better than tamoxifen alone. The 8-year survival curves are on top of each other. Efficiency-wise, this is a much better therapy. Next. Adherence to treatment, okay? Adherence to treatment is a problem with all kinds of treatments worldwide. These curves, I could take away saying these curves are for tamoxifen or tamoxifen followed by AI, and instead put in a hypertensive drug, put in an asthmatic drug, put in a diabetic drug, okay? Say I'm studying Swedish patients, say I'm studying Bangladeshi patients, okay? The curves would look the same, okay? You can see that the proportion who are continuing to treat, by the time you get to 2 years to 3 years, less than 50% are taking the drug, okay? And in the case of the red curve, which is tamoxifen, then changed to AIs, you see worse, and it's worse because the symptomatology associated with AIs, okay, is just disastrous for patients. Bone pain, muscle pain are a big problem with AIs, okay? And it all comes up in this, okay? So getting people to take this separate from the financial costs is just an unrealistic proposition. I show you these particular data because the numbers are big, okay, and it's a population data series, okay? It's what happens in the real world. Next. Does adherence matter? I've showed you adherence. Here's some big data set, 8,000 patients, okay? Does it matter if people are taking treatment continuously in the first 5 years? It sure does. There's a 7% difference between those that are really taking treatment and those that aren't, okay? And if we do things like only 1 year of treatment as opposed to 5, you can imagine the differences are bigger. Next. So what the Cochrane people say is that in the real world, our differences in outcomes with treatment are likely to be much worse than we see in clinical trial reports. The population data tell us a different story. There's no cure for non-adherence, okay? We are not very smart, and we haven't done a better job. Hypertension, tamoxifen, whatever, in 40 years, okay? This really brings home that a treatment option like surgical oophorectomy, where everybody gets it, okay, is important, okay? We've got to think more about how patients behave and how societies influence behavior if we're going to do a better job with compliance with oral treatments. But if you can do a better job in treating your patients in this category, surgical oophorectomy has the advantage that unquestionably the patient has gotten treated. Next. So let's go back to the questions, okay? I think most of you thought that there were more pre than post. In fact, as best we can determine, the numbers are about equivalent, okay? It depends. There are some reasonable data sets that suggest there are more premenopausal than postmenopausal women. It obviously depends on your age pyramid. If you've got a very flat age pyramid with everybody being young, okay, and not very many older people, even though your rates are going to be higher with older people, if you don't have very many older people to be subjected to those rates, you're not going to have any cases, okay? So globally, the answer is it's about the same, okay? So in the West, it's only about 20% of cases are premenopausal, okay? So the jumping up and down in the West about premenopausal women is for a minority of patients, okay? And that's partially why this issue of how to treat premenopausal patients has not received as much attention. Next. I think most of you felt that thinking about C was appropriate, okay? And you're right, okay? It's how our systems work, okay? Broad economic issues of what gets funded and what doesn't get funded, okay? It's not the high costs of therapy. Your costs of most basic therapies here are, yes, for poor people a challenge, but for most therapies, not a big deal, okay? Or there are support mechanisms. It's not, except for new things, the high costs of therapy globally, okay? It's uncomfortable situations of how our systems work and bribes and corruption and all kinds of things where money speaks of the wrong way. Part of the reason that I want to throw this question out at you is you may ask me, and so I'm going to preempt you, okay? Well, listen, why is the situation that the standard of therapy in the West continues to be LHRH agonists? And why did ASCO, in fact, in its recent guidelines, omit surgical oophorectomy as a therapeutic option for the first time? Okay? Why did that happen? Okay? The answer is, I don't know. I'm not omniscient, okay? But it has to do with number 3, C, economic issues, okay? Let us compare Professor Powdell's salary with the salary of the CEO of AstraZeneca, the main provider of Zoladex, okay? Do you think his salary is 1 million times smaller? 10 million times smaller? Maybe only 10,000 times smaller, okay? Look it up, okay? It's embarrassing. It's embarrassing, okay? So I think that's where it's at. Those of you that get to ASCO, okay? ASCO is a pharmaco-oncologic operation, okay? With huge support from the pharmaceutical industry, okay? And that's what it's about. It's about money. Next.
Just to support this, right? I'm also a great believer that it's the governance which is important. Like we in Nepal also, it's not the money. That money is not the factor not to get the cancer patient. All cancer patients get the treatment. I'll give you an example. On tobacco tax, every year 10 to 15 billion rupees is collected in the ministry. Even I am a board member of that tobacco tax, and you might get further. Even for the hospital, we provide 100,000. We call it 1 crore, 100,000, $1 lakh equivalent money for the cancer treatment. Even you might be get further that the hospital so far could never ever could finish that money. 1 crore cancer patients of the hospital. हरेक साल मैले दिइरहेको छु एज अ बोर्ड टोबाको ट्याक्स बोर्ड मेम्बर every year 10-15 billion rupees is collected next, which we never spread. So money is not the problem, it's a governance. It's a governance. People say mad when I say these things. I'm happy that you also said these things.
So governance involves guidelines, okay? And governance from our side, I mean, part of the problem with the treatment of these people, and the reason that I'm delighted that a number of surgeons have come today, okay, is somehow we got this idea that breast cancer should be treated by medical oncologists, okay? And you surgeons, there's a technical issue. You go and do this operation and then get out of the picture, and we'll decide about treatment. Nonsense. Okay? Absolute nonsense. Okay? You know, up front, you should be asking questions about hormone receptor status, HER2 status, and you should be thinking about concurrent surgical oophorectomy and breast surgery at the same time. Okay? All right? And they, you know, should be blessing it and happy. Okay? Third question. What can the absolute survival increase be? As I suggested to you, in fact, it can be huge. Again, the global issue is important, okay? The reason the absolute number is bigger than what you hear from meta-analysis data and so on is because globally, in reasonable circumstances, 60% of patients are axillary node positive, okay? Their risk is higher. So the absolute benefit that they can derive from hormonal treatment, okay, is high. Ours was 33%, okay? So I think globally a reasonable goal is 25%. Well, a treatment that can increase overall survival by 25%, okay, is, you know, that's pretty good, okay? Next. Number 4. I think everybody got this, and now you've seen that graph, you'll remember it. Adherence is a bad issue, okay? The fraction with hormone therapy is less than 50%, okay? And so if you look at the SOFT trial and the TEXT trial, okay, and you look at their numbers, okay, they say that 80% of patients took the therapy for 5 years, okay? All right? My view is those were special trial circumstances, but my view also is that if you believe that, you believe in the tooth fairy, okay? I don't think they're getting accurate data, okay? And finally, the last question, okay? The rigorous data are that for standard chemotherapy regimens, okay, we are seeing hard objective evidence of significant impairment, significant statistically, but significant for patients, impairment of cognitive function in at least a quarter of patients, okay? So this business, as Professor was saying when I talked to you about the Taylor trial, we'll give chemotherapy just to be safe, okay? That's fine, okay? If you want to accept that a quarter of the patients you do that to, okay, are going to lose cognitive function, okay? And it's going to be significant, okay? That's fine, okay? But it's not fine, all right? So this is an area we've all got to be, on the medical oncology side, we got to be more sensitive to. But you surgeons have got to be aware of when you say, we're going to do good hormone treatment, okay? Now, it's fair for you to ask, what about, in closing, what about surgery and tamoxifen in terms of CNS effects? We showed that tamoxifen in postmenopausal women unquestionably affects liver function and would be expected to improve cardiovascular outcomes. And it does. It does. Total cholesterol goes down, LDL cholesterol goes down, and various measures of long-term cardiovascular health are much better. Lower stroke rates, etc. Okay? The CNS question is unclear. Whether tamoxifen is an anti-estrogen to the brain or an estrogen to the brain, I don't know. Okay? What I do know is that AIs are an anti-estrogen to the brain. Okay? And there are problems with AIs long-term. Okay? So that's where we are with tamoxifen. Okay? I think we're probably better off with tamoxifen on top of surgical oophorectomy than surgical oophorectomy or LAHRH alone. Okay? So, what I hope I've shown you is a practical solution that I think can make a difference because it's something people can get. It's associated with good outcomes, and there are a number of people that could benefit. So one more. So just leave it here, okay? So let's just leave it here thinking about a patient and give you an opportunity to challenge me or ask questions.
Okay, the questions, time for questions even for our colleagues from the other parts of the hospitals. So Parson Hospital, from Model Hospital, Dr. Uday. Any questions? Any suggestions? उनीहरूको ठुलो पार्नु छ नि है होइन उनीहरूको स्क्रिनमा ठुलो पार्नु यो चेन्ज गर्नु छ कहिले यसो चेन्ज गरेर फेरि टेलिभिजन जस्तो देखिन्छ होला अलिकति any questions from any part? Yes? Yeah. Yes. Dr. Uday is a very renowned surgeon in the Model Hospital.
Okay. Thank you for listening.
Thank you. Thank you, Professor, for this nice and long session. Professor Lau. What is the difference in oophorectomy alone without tamoxifen and without resuscitation?
Keep a sound, keep it. Quick. It like sound
Can you hear us?
I think he's asking surgery without damage.
Right.
Yeah.
Can you hear us? Can you hear me now?
Yeah.
Sound yeah.
Are you listening, sir?
Oh, I listen.
So what?
So you mean only oophorectomy, no tamoxifen?
Yeah, because you are telling that.
Right. Okay. So if your question is, if you do oophorectomy and then the patient for one reason or another doesn't take tamoxifen, okay? What I can tell you is the data show in terms of breast cancer recurrence, major benefit, okay? In terms of bone, the major toxicity, you will see bone loss, okay? So the benefit of tamoxifen is you'll see greater efficacy than with just oophorectomy alone, and tamoxifen prevents, those are the big parameters, okay? I'm willing to live with the fact that patients drop out of therapy with tamoxifen, even if they get oophorectomy, because the level of benefit from oophorectomy is huge in hormone receptor positive patients like this, okay? And so maybe I get some patients with osteoporosis, okay, but I'm going to have a lot more patients at 10 years who are alive.
Any questions from the Parson Hospital? Dr. Uday, I think he's asking.
So
yeah.
What the dose? Will you reduce the dose of tamoxifen?
20 milligrams, okay? There were a number of studies looking at dose relationships with tamoxifen, okay? And the higher dose studies really didn't show very much. It's reasonable to ask, well, what about lower dose, particularly if cost issues come up or whatever, okay? The answer is you probably lose something with taking 10 milligrams as opposed to 20, okay? But maybe you don't lose very much, okay? So if I have patients with really severe symptoms, that is to say hot flashes from tamoxifen, the first thing I'll do potentially is have the dose, okay? And that's another subject I should just quickly say something about. In the West, there's been a lot of jumping up and down about symptoms, okay? And one of the reasons people have advocated giving drug treatment as opposed to surgical treatment to the ovary is they say, well, it's reversible, okay? Oh, give me a break, okay? The reason I talk to you about long-term chronicity of treatment is you've got to get into long-term ovarian suppression anyway, okay? Our data showed that after a year, the symptom levels in patients, typical vasomotor symptoms, hot flashes, were no different in patients who received surgical oophorectomy and then tamoxifen than patients who got no treatment at all, okay? Things quieted down very fast, okay?
Any query from the Patna Hospital? Patna Hospital, Sunita?
No?
Sunita? Okay, question? Okay, query? Patna Hospital, Ajay?
We don't have query.
छैन? ल थ्याङ्क यू डाक्टर उदय तपाईको माइक कहाँ छ डाक्टर उदय माइक कहाँ छ तपाईको माइक
अगाडि छ त
अहिले अघि राम्रो सुनेको थिएन कि माइक अलि टाढा भयो कि जस्तो लाग्यो नि अहिले चाहिँ अलि नजिक आएपछि चाहिँ अहिले ओके जस्ट टेस्टिङ गरेको मैले के भएछ भनेर
About the chronic disease story is that it's very clear that giving therapy beyond 5 years, up to 10 years, reduces risk of recurrence in these people, okay? And it may be that continuing therapy after 10 years would be helpful. I have a number of patients whom were node positive in particular, or even regionally advanced patients that were node positive, whom I basically continued on tamoxifen for life. Because early on I felt that we were seeing a picture of chronic disease and that some hormonal treatment continuing was going to be beneficial, okay? That's tough, you know, from a practical standpoint, it seems tough, but that's where we are. Do I wish we had, you know, other ways of doing this, you know, with, I don't know, that people could get a long-acting subcutaneous injection or something like that? Sure, but at the present time, that's the best that we have. In an editorial that accompanied this Taylor trial, a woman whom I like, okay, Vered Stearns from Hopkins, said, you know, what should follow from this kind of work about the importance of hormonal treatment is trying to improve on the hormonal treatment, okay? And my answer, okay, is don't talk to me about new drugs and trying to improve it until you understand the biology that we have talked about and until we do a fair and equitable job of getting treatment to our women colleagues across the world who at the present time aren't getting treatment because they're told, and their doctors are told from the United States, that the only treatment that's any good is LHRH agonist, and financially that's out of reach of people. So they're told Hobson's choice, okay? You can have this high-cost treatment or you can have no treatment, okay? And they're never given the option, okay? That is an issue of social justice that I feel obviously strongly about is bad. And we need to pay a lot more attention to that issue.
Just to make clear, we are discussing here the duration of a tamoxifen in a oophorectomy patient.
Yes.
So when we are discussing during the duration, the first 5 years of tamoxifen is must.
Yes.
That do the most effectively. If
Yes.
you continue for another 5 years, then the benefit is there, but not as much as benefit as the first 5 years. That thing has to be understood. So 5 years is a must. If possible, go for 10 years. One option. Another thing is that if the patient can afford, you can change the tamoxifen to aromatase inhibitors after 5 years. The studies have shown that aromatase inhibitors compared to the tamoxifen better. And in aromatase inhibitor also, aromycin exemestane has shown better results. So these are the options. 5 years must, that's Professor Love will correct me, 5 years must, if possible 10 years, or you can change to the aromatase inhibitors.
I think generally I'd agree. I'm not a fan of aromatase inhibitors, okay? I think the cost issues, I think the side effect issues are bad, and I think, in fact, the comparisons with tamoxifen are not as just as they should be, okay? So I'm really not a fan of aromatase inhibitors, okay?
No, what I'm saying, those are the also.
But it's an option, okay?
Yeah.
So my second question is, as a surgeon, we are not so much committed for surgical oophorectomy right now.
Right.
So today we hear your lecture, so
Right.
we are going to think about it.
Right.
So in your center, does a general surgeon does a oophorectomy or a gynecologist does a oophorectomy?
Sure, in general, in the United States, gynecologic surgeons do.
So it's a laparoscopy or open surgery?
Both, okay, both. You know, in many countries where I worked, in Bangladesh, where we had a large number of patients on the metastatic study, okay, the general surgeons, the general surgeons, there's kind of a subgroup of general surgeons who tended to do breast and gynecologic surgery, okay? And they were very comfortable doing both of those procedures under the same anesthesia, okay? So it varies in countries, but in the United States, it's gynecologic surgeons that do.
It's a simple procedure.
Yeah.
Yes,
Yeah.
yeah.
As a medical officer.
Laparoscopic absolutely makes, you know,
As a family planning methods also. we use.
makes good sense. Makes good sense.
Since you have done, my question is
Yeah.
regarding the surgical scheduling of the patient.
Yes,
Since you have done a much part of the surgery in Vietnam,
yeah,
and I think that's very similar to our condition that is over here.
okay,
At the central hospital in the hospital, we have a big surgical room.
yeah.
Can you suggest how we can manage patients for scheduling them during exactly their follicular phase? How we manage to do that in Vietnam?
And for this study, okay? All I can tell you is in Vietnam and the Philippines, taking the approach that we did, okay? We had people that take histories and then schedule patients, okay? Based on the randomization, okay? And in general, those schedules worked, okay? In other words, people were able to stick to the schedule. You know, sometimes family issues for patients or emergency issues for the operating room came up and so on. I'm not a surgeon, and so I'm not used to those kinds of problems. All I can tell you is they managed them very well. In the United States, I regularly get calls from people who become aware of this, and then when I talk to them and subsequently talk to their doctors, they manage to do this without a lot of difficulty, even though the scheduling issue is the same, okay? That the pressures are the same, okay? Well, let me take you a little bit to task, okay? I'm a little bit surprised that nobody has turned on me and said, well, listen, you're showing us these clinical data, and you're convinced about the clinical data, but wait a second, how does this work? My guess is that maybe the wheels have turned and you wondered, wait a second.
Basically, hormone deprivation therapy.
Yeah. But wait a second.
We are hearing this about the things reducing oophorectomy or bilateral oophorectomy since several years. So it was in our text, like doing a rich reduction, this bilateral mastectomy was.
All right. Okay.
Oophorectomy that was there since several years, but we have never gone into the therapeutic aspect of this oophorectomy.
All right. But what I'm saying is, look, I'm showing you that when a surgical oophorectomy is done makes a difference, okay, in the outcomes, okay? And what I'm saying is, wait a second, okay? You mean to say that if I do the surgery today as opposed to doing the surgery from a week from now, it's going to have some kind of huge difference in outcome? Why should that be? The general effects and the general model of thinking about surgical oophorectomy has been a long-term, sustained, decreased estrogen level. What I'm describing to you is saying, wait a second, there's an acute effect occurring here, okay? All right? So let me talk about that for a second. What do I think is going on? Well, those of you that are older know that before we got into an age of various other interventions, for metastatic prostate cancer, we would have men who appeared with metastatic disease, and we did orchiectomies, okay? And what happened to those men symptomatically, okay? If you're old enough to know, what happened to those men is they would have acute responses. They would literally come into the hospital on pain medicine, okay? On big doses of this, and keep this because I'm going to look at a slide in a minute, okay? On big doses of pain medicine, they'd have an orchiectomy, okay? And they'd say, I don't need my pain medicine anymore, okay? Now, I won't say that they were chasing the nurses up and down the hall, okay? But, okay, in fact, our clinical problem with men at that time was they needed to have their narcotics tapered. And they were saying, I don't need it anymore, okay? So they were having an acute effect of orchiectomy, okay? Now, as you know, that treatment has a sustained long-term effect in the same way surgical oophorectomy does, okay? But the model that a component of the effect is acute and beneficial is not one we've thought about with respect to surgical oophorectomy, okay? So here's what I think, next slide, is going on, okay? Patients who get surgical oophorectomy in prolonged follicular phase or luteal phase but no progesterone, okay? They get very little benefit from this treatment, okay? And in fact, it's shocking that even though we were giving them tamoxifen, they got so little benefit, okay? Why is this, okay? First, on average, if this is true, if we take our population of people in these three groups, follicular phase, confirmed. Luteal phase, confirmed. Prolonged follicular phase. The numbers are about equivalent, okay? If just random population, they're about equivalent, okay? If, therefore, we remove those bad actors, those prolonged follicular patients, and we don't treat them, okay? Or we wait until they're in the right time, okay? On average, confirmed follicular luteal patients have got to do better, okay? And on average, we've calculated that if you do this, on average, as opposed to not paying any attention to history at all, if you had a couple hundred patients and you paid attention to history and you didn't pay attention to history, the people in whom you paid attention to history would do 7 or 8% at 5 years, okay? Why? Next. Why does this work? Okay? It works, and my colleagues in the lab think it works because what's going on is there's prolonged exposure to already micrometastatic cells to high levels of estradiol from about day 7 in the cycle, beyond day 14, out to maybe day 21. Without any opposing progesterone rescue, okay? They never get opposing rescue because they have oophorectomies, and they never get a follicle, and they never get progesterone, okay? Now, if you talk to people in the lab, okay, working with breast cancer cultures and so on, they'll tell you that the most powerful growth mitogen is estradiol. It's very powerful, okay? So the last signal that those micrometastatic cells that are already out there get, okay, is a prolonged estradiol signal. And they never get a contrary progesterone signal, okay? This is consistent with, you may know, my friend Raj Badwe's data about giving high-dose progesterone to women before surgery, okay? And that such women did better, okay? Because progesterone protects against estradiol effects, okay? So that's what I think is going on, okay? That estradiol, what these women get is 14 days of high levels of estradiol, okay? And that is stimulating the growth of micrometastatic clones of cells already there. And then instead of having a natural cycle where progesterone comes along and counteracts, okay, they don't get any progesterone because they have an oophorectomy, okay? Does this make sense? It's consistent with all kinds of animal models, Bodway's data, okay, and everything we know about estradiol. So that's what I think is going on. Other questions?
Excuse me.
Sure.
And what is the reason behind that in the metastatic settings? The timing of this hormonal is timing while we is not very efficient in the metastatic settings.
No, I think the same thing is going on. Remember that in the metastatic, here's how I reasoned doing a metastatic study as well as an adjuvant study, okay? Why do patients with metastatic breast cancer die, okay? So the patient comes to you with a spinal metastasis, recurrence in the neck, okay? All right? Now, that spinal metastasis usually, that recurrence in the neck doesn't kill the patient, okay? You can get your surgical colleagues to come and take out the nodes in the neck, okay? You can send the patient to radiotherapy and radiate the place in the spine, okay? All right? Why doesn't the patient go on with metastatic disease, declare about that, and die? The patient goes on to die because she develops growth of already present micrometastatic disease that you can't see in other places, okay? So what we did in the metastatic study was we gave a treatment that could be effective for already known disease, but the key thing that we did was we treated unrecognized micrometastatic disease, which was the same thing we were doing in the adjuvant setting. And that treatment prolonged patients' lives. That's why it worked there too. That's what I see.
I think we will go to the 10-minute session. Yeah, go to continue. Thank you, the friends from the partner hospital and then model hospital. So I hope the professor loved. No, she's in Alta. Huh? Okay. So thank you. So hope in the future also this telemedicine session will be continued. Okay. Thank you very much.
Thank you.